The Western eye surgeon worries about the best size of a rhexis, or the best type of implant, and he thinks that couching disappeared in 1748 when Jacques Daviel first demonstrated extraction. He may not be aware that in many countries on this earth, couching is still performed to this very day. In Nigeria, for example, some 200 couchers perform surgery and deliver eye care to a large percentage of the population. We set out to visit several couchers in northern Nigeria. It was most difficult to establish contact as they did not want to disclose professional secrets.
But the trouble is that less than 14% of Nigerians have Western-style coverage of health care services. That means about 85% of Nigerians have to resort to traditional health care in one form or the other.
After long and delicate negotiations, and after supplying a substantial consultancy fee, a few couchers were prepared to talk to us. We believe that this videotape of an actual couching session is a first. One of the traditional eye doctors, as they prefer to call themselves, is Dr. Haruna Isa. He lives in Kafanchan, a small provincial town 120 miles south of Kaduna. We followed Isa to his private hospital, one block down from his home on Main Street. He is presently adding some more patient rooms for better follow-up. The first of the patients is already waiting. Isa explains. I learned couching from my grandfather. He in turn was taught by his father. I was an apprentice for 10 years and first practiced surgery on animals. I use traditional medicines, which I prepare myself, but I also use Western drugs and treat couched eyes with cortisone eye drops. We were wondering whether Isa would depress or recline the cataracts of his patients. In reclination, the superior zonule is ruptured and the lens is then tumbled backwards into the vitreous. In depression, the inferior zonules are broken first, and the lens is then pushed down with the inferior equator leading. The first patient is prepared for surgery. He is sitting on the floor of the hospital. A topical anesthetic has been instilled, mixed by Isa himself according to his grandfather's prescription. A brief preoperative scrubbing maneuver appears to be more ritual and symbolic than effective, as does the subsequent drying of his hands with a cotton cloth. The use of a face mask also seems to be a loan from Western-style medicine. The couching needle is produced from a pocket of Isa's kaftan. The eye is stabilized with the coucher's thumb. The needle is introduced perpendicularly into the eye, entering 3 millimeters behind the limbus. It is gradually pushed forward with a rotating movement. The needle tip is moved downwards and disrupts the lower zonule. With some sweeping movements, the whole lens is then pushed down into the vitreous. This maneuver is therefore a cataract depression. The needle appears behind the empty black pupil. It is swept up and down several times to make sure that the cataract will not rise again. Some tears are wiped away from the patient's face. The patient opens his eyes and he can see. Dr. Issa demonstrates that he is now able to count fingers. Both he and the patient appear relieved. With a bundle of Nigerian naira, the coucher's son is dispatched to buy cortisone eye drops from the local pharmacist. We ask how the patient chose his surgeon. I went to Dr. Haruna because he has operated on members of my family with very good success. He is well known in the region. The needle is sterilized in a plastic pot with an immersion heater. It is carefully wiped clean with some cotton before the second patient is prepared. It is again a right eye. Some drops are instilled, and again the needle is introduced 3 millimeters behind the limbus. The lens is pushed down, and the same sweeping movements with the needle are performed to ensure safe dislocation. And again, the patient's instant vision is ascertained by letting him count fingers. The cataract needle is covered with its fountain pen-like top. After a couple of minutes, a more detailed functional examination is performed. The patient is able to count fingers, name objects, and describe the coucher's position from a distance of several yards. Both patients are happy and relieved. I have come from 30 miles away for the operation. I will also have him operate on my second eye. Going to a Western doctor did not enter my mind. About his surgery, Dr. Issa Haruna explains. To justify surgery, the cataract must be ripe. Ripeness depends on 3 signs. The cataract must be really white, the pupil should react, and the patient should be able to see light. If the cataract is not mature, it should be postponed. With these precautions, complications are rare. This was confirmed by our Western Nigerian colleagues. They observe occasional pharcolytic inflammations and secondary glaucomas, while endophthalmitis, astonishingly enough, is extremely rare. Dr. Haruna Issa showed us his diploma of a traditional herbalist healers association.
I believe a great proportion of people go to the couches and they get the services done and they get the visual benefit. So I have no grudge against it. But what I would want to say is we need to study it closely, to collaborate with these people, to try and correct the mistakes they might make.
We have to accept Issa's couching needle is better than no treatment at all. Couching will only disappear when high-quality Western-style implant surgery becomes available to everybody. But until then, we have a long way to go. So when we talk about the size of the rhexis and the best type of implant, we should not forget that cataracts in rural Africa may mean an altogether different matter.